So again, this is a talk that we'll be doing today. It's actually pretty interesting stuff, and we'll talk about that momentarily. Otherwise, next slide.
So as we have said for a few months now already, we are going to be switching to a new Echo platform that starts December 6th, which is coming up soon. So if you haven't registered for your new iEcho account, please do so, because the Zoom link will no longer be activated after December 6th.
Yep. Reruns a lassie when you try and get in. We have a lot of different talks coming up that should be pretty interesting. We actually have a lawyer on the 29th on evidence-based treatment in correctional settings, but lots of different talks coming up. So feel free to keep checking on those, the ones that are of interest to you.
And there is free CME offered for these sessions. We don't care if you're eating lunch. Please turn your camera on and participate as much as you can. We love to see your faces.
And remember, if you need help, please give us a call. We're happy to give you some advice and help you kind of navigate some of these tough patients that we all see. So our numbers are there. You can give us a call, email, whatever you like.
And then Stratus Health is the home to the CORE website that has a number of different opioid and addiction-related resources to check out.
Oh, and now the talk. And actually, if people noticed, I am wearing a tie today. I rarely wear a tie. I've had about 30 people stop me and wondered what was different. And I have a tie on. So hopefully that'll make things run more smoothly today. So alcohol and benzos is kind of an interesting topic for me. And I think that having done obstetrics for about 20 years, I can tell you in my era of delivering babies back even 30 years ago, these things were interestingly used, and benzodiazepines were often, we didn't use them ever in pregnancy because of the fear of especially cleft palates and things like that, which we're going to talk about. I am old enough, sadly, to have had conversations with obstetricians who used alcohol to stop preterm labor, if you can imagine, and maybe some of you have heard of that. It worked relatively well, but you had a patient who was relatively inebriated, and those were some pretty interesting times in small town America where they would use that. So just again, historically, there's a lot of interesting things with alcohol and benzos. Next slide. We're gonna talk a little bit about especially the screening for alcohol. One of the things that I find interesting is we screen for everything else, but we typically, with pregnant patients, do not screen for alcohol much, right? That just doesn't happen. We might ask about it, but we don't do urine drug screens that often will have alcohol. Some people may. And we're going to talk about some of those adverse outcomes of alcohol and benzos, as well as some of the things that we might consider for withdrawal, which with alcohol and benzodiazepines can be somewhat similar. Next slide. So what's really the scope of the perinatal substance use? I think we have to understand that this is really a big public health concern. And really, when you look at some of the bigger studies that are done nationwide over the last 10 years, we have seen an enormous change in the legal and the legal and illegal substances that have been used really in each trimester over the past 10 years. And so the numbers have changed. And a lot of that can be even related to the legalization of marijuana, some of the other things that are over the counter, the things like kratom and other different things that patients may use. Next slide. So lots of interesting data. And if we look at the illegal substances used in the last month, way back in 2009, really less than 5% of people were using things that were illegal, whereas you fast forward 10 years and it's tripled the number of illicit substances used in the past month. When you look at, again, legal substances, and now some of that in some states can include marijuana, it's also gone up 4 times. It's gone up substantially. And again, we do have a lot of things that are sold over the counter that are considered legal, especially when we look at things like CBD, when we look at some of the marijuana products and edibles, all these different things that are legal, they're being used very frequently now as compared to 10 years ago. Next slide. As we would expect, it does change quite a bit when we look at the trimesters of use. And I think, those of you who have done obstetrics or have worked with patients who are pregnant, oftentimes people are doing things in their first trimester, and when they find out they're pregnant, they stop very quickly. And I certainly saw that a lot. I think back 10 or 15 years ago, I probably did a poor job of continuing that screening and asking the questions about all these different substances. I think it's funny when I look back and I think about it, I think a lot of my focus really was smoking, because smoking was so common, and we would have patients smoking through their whole pregnancies. But if you look at what happens during their pregnancy, we do see a decline from second and third trimesters in the types of substances people use and how often. So really by the second and third trimester, the amounts and the polysubstance use actually decreases. And again, I don't think this is surprising. I think most people, when they find out that they're pregnant, are worried about their baby and are going to make changes. Next slide. So a little bit of general information about the benzos as far as pregnancy goes. Next slide. And again, when we look at benzodiazepines and we look at, how often do people end up in the hospitals with complications of illicit benzodiazepines, it's actually relatively rare. It's gone up a lot, and really from 2000 to 2010, it pretty much tripled how much more we saw these patients in the hospitals and admitted to the hospitals. Really, almost 60,000 admits in those 10 years. And I think that when we think about now how many of our patients are buying these things online, and I see that very frequently, that people are getting bromazepam, other different types of designer benzodiazepines from overseas that are getting sold, we will often get these patients in our clinic and we honestly can't even identify exactly what they have. It can come as a powder. We've seen it as liquid. And so there's lots of different ways that these patients are obtaining it and using it. Next slide. And when we talk about kind of the impact, if you look at what percentage of these people are using something else, it's actually relatively high. And if you look at really benzodiazepines, 95% of the benzodiazepines admissions actually have other substances. And I don't think that's a surprise as well. I'd say it's very rare that I will see a patient have a urine drug screen done and it's only benzodiazepine. That's usually something that's added to the things that they're using and is just kind of a part of their experience. 83% of the time, the benzodiazepine is actually kind of that secondary drug. It's the dessert, if you will. They'll be using something else, and then they'll use a benzodiazepine sometimes to help extend how these different substances might appeal to them. Next slide. So when are they prescribed? And it's, again, interestingly, when I was doing obstetrics years ago, this was really a no-no. People did not prescribe benzodiazepines during pregnancies. And if we look at worldwide, it's actually relatively common. 3% of pregnancies in 22 surveyed countries have people being prescribed benzodiazepines. Our statistics, despite the fact that we still have some of these medications being prescribed, our numbers are really pretty low. And you can see 0.014%. Places like France, 3% of pregnant women in France are on a benzodiazepine. And I think 20 years ago, when we were concerned about some of the craniofacial issues, these numbers were much lower. As I'll show you some of the studies and some of the different things that have been really reviewed and some of the case reports, I think that there's a lot less of the craniofacial issues than people really thought. And so we're seeing more people get these things prescribed. Next slide. So also, the way that they're prescribed during pregnancy can be vastly different. So you'll get some patients who continue on the benzodiazepine during their entire pregnancy. And so if you count both the people that can get it continuous and those that get it intermittent, still almost 5% of infants will actually be exposed during that first trimester. And I think that one of the things is that you really need to understand what are the effects of this? And that's the problem. There is very little maternal or fetal health information. Much of this is from animal studies. Much of this is just from more case reports and different things as the years have gone on. Next slide. So we'll talk a little bit about the exposures and some of the reviews and meta-analysis that have been done on benzodiazepines. Now, the biggest part of this really is that when they really look back at all the different reviews and meta-analysis on benzodiazepine use during pregnancies, the fact that early on there was this big thought that they were teratogenic, and again, the big concern always being the cleft palates, has somewhat fallen by the wayside, which I think surprises a lot of us. I think, in my early years of my career, that was just something that everybody knew, that benzos would cause that particular issue. That's not to say that there are not problems. And in fact, we see different issues, especially early on in pregnancy, with spontaneous abortions, with preterm births. Much like smoking, we get small for gestational age babies, and frequently low APGAR babies, especially if moms are taking them later in pregnancy. There is a lot of information in the literature about third trimester use, and especially babies getting what's called floppy infant syndrome. And to be honest, that could be a whole talk about babies born when mom is actually taking a benzodiazepine. These are typically babies that are a little bit more flaccid. They're not good feeders, a little bit of a failure to thrive. But again, that's like a whole nother talk that we could spend a couple of hours on. Next slide. So we can also get withdrawal. And again, withdrawal of benzodiazepines, much like alcohol, can be a pretty risky issue. I think it's no different than any type of drug or substance, that the more that somebody's using, the more likely they're going to have trouble, the more likely the trouble they have is going to be severe. And so when we look at benzodiazepines in particular, it can really make a difference at what dose they're taking, whether they've actually been tapering. And I talk about this with students all the time, because when we see patients that are withdrawing from any substance, it's really important to know, did they just go from taking 10 pills a day to stopping today, or were they slowly tapering themselves over the last week or two? Because that makes a big difference really in how we're going to approach them. And so have they been tapering, and what's the potency of the benzo? Some of the issue that we see in my clinic is that I don't know the potency of the benzo they're taking, because they're getting it from China. And so we can look it up, but from knowing today what that particular substance is almost impossible. They will bring it in, and often it will pop for positive on our screen, but when we send it in, we won't get a confirmatory of anything. And so it can be very, very difficult sometimes to know what to do, especially the day that a patient shows up, and especially if they're pregnant. Next slide. So again, very similar to alcohol withdrawal. And again, I think that when we talk to patients, we always want to make sure that they understand that these aren't things that they can just stop. This, much like alcohol, can be a life-threatening thing. And so we can't just let people tough it out. I had a person just yesterday who was taking these types of medications and was just going to stop. And it took me a long time to get through to the patient that we can't just stop these medications, that we have to have a plan. And of course, in pregnant women, we have all kinds of other issues that can arise, including placental abruptions, preterm labor, fetal distress. And so this is a type of patient that's often going to need to be in the hospital. They need to be monitored very carefully if they're pregnant, because we can't afford for them to have a seizure and some of the things that might result from that. Next slide. So if a patient has any real symptoms of significance, again, and especially if they have other things on board. I mean, it's pretty rare that we will see somebody showing up in a clinic who's taking just one medication or one substance. Often they will be taking opioids, they will be taking benzodiazepines, they may be using methamphetamine, and more often than not, they're also smoking marijuana. So what their actual withdrawal may look like may be very difficult to really characterize. So I think it's important that we get a great history. We need to know what they're going to do. We don't ever want people when they're pregnant withdrawing from opioids wherever they are, in the ER, the jail. We want to make sure that we're treating those people. And benzodiazepines is really the same way. If a patient is pregnant, we want to make sure that they get the treatment, the taper, and the evaluation that's going to keep them and their baby safe. So one of the things that when we look at this is which ones do we consider using for the taper? Now, when we look at alcohol, which we're going to talk about in a minute, there's lots of different medicines in a non-pregnant person that we may consider using for their withdrawal. When we look at pregnancy, we have to look at the medications that are relatively safe and will actually work, won't cause any long-standing problems with the baby or mom. And so we're often looking at those intermediate and longer-acting benzos. Most of the studies, and again, it's not like there's a million studies out there. When we're looking at pregnant women and we're looking at how are we going to get them through their withdrawal, there's been a lot of research and really looking back at what seems to be best for this patient, whether we're going to drive how much their dose is based on what their symptoms are, or are we going to look more at just putting them on a schedule. And I think most of the studies have really recommended that we treat the patients as they get symptoms, and because in the end they actually get less of the benzodiazepine, and we can slowly wean them down over days, anywhere from 3 to 10 days, depending on what they might be taking. Next slide. So again, remember, alcohol, lots of other drugs to think about. One of the things we think about really with both alcohol and benzodiazepines is how long do we go? And I can tell you that there is also not great data for that. Even when we look at people who are not pregnant, every hospital has their own little protocol that they use. And it may go anywhere from just a few days to 7 to 8 to 9 or 10 days. And so for a pregnant woman, again, it has to be very closely watched, and their symptoms have to be very closely evaluated. And as they come down and their symptoms improve, then we can kind of slowly taper them off and remove the benzodiazepine completely. Next slide. So let's switch over and let's talk about alcohol. And again, I think it's interesting how similar the problems can be with alcohol as they can be with benzos. I think that one of the funny things with alcohol is, again, like I said, I think it's one of the things that we should always be screening for that we often don't. And again, the urine drug screens will not typically, at least in our clinic, they will not pick up alcohol. We have to do a breathalyzer. And so a lot of times patients that come in that are new patients to us that are also pregnant, we will have to do something like that to see whether or not they're actually drinking alcohol as well. There are obviously blood and urine tests that can be done, but I think often these things are not done. We tend to prioritize what we see the most of in our clinic, which is right at the moment probably still fentanyl and methamphetamine. But if you look at alcohol use in the last 12 months, 65% of pregnant respondents had used some alcohol in the last 12 months. So this is a group that has got significant intake. And if you look at those women in their first trimester, almost 20% said that they'd had at least one drink in the last 30 days. I don't know that we're getting that good of information sometimes when we're first seeing the patient. And again, as we had said earlier, people tend to do less of these types of substances in their second and third trimester. So if you look at this group, 5% of the respondents in their second or third trimester reported, at least one drink in 30 days, but it's certainly gone down. I think the thing that we have to worry about sometimes is the binge drinking. There still seems to be in pregnancy a fair amount of binge drinking, and for women would be considered more than 4 drinks at one time, which obviously is going to have a significant effect. And that's noted in the last 30 days. Remember, if people are binging during that pregnancy, typically it's highest in that first trimester, again, often because patients may not know that they're pregnant. Next slide. So At-risk drinking, here's the thing that we think about all the time. I have conversations with patients all the time about what at-risk drinking is as far as a male and a female. And of course, when we talk about non-pregnant females, we're kind of leaning towards that 7 drinks a week. Anything above that is probably an at-risk drinker. Does it mean they have an alcohol use disorder? Not necessarily, but it puts them in a different risk level. Now we've got a woman in our clinic and she becomes pregnant, and we have to say, well, at-risk drinking for you is anything more than 0. Okay, that's really where the line is. And the reason is any alcohol has been shown to be considered unhealthy during pregnancy and has the potential to cause problems for that patient. Next slide. So how about the rest of the world? And honestly, I found this fascinating and scary all at the same time. I think that, having a father of Irish descent, and I look at Ireland, 60% of women in Ireland are drinking to some degree during their pregnancies. I think that is absolutely shocking. When we look at Saudi Arabia at 0, when we look at Europe, and of course in Europe, it is not uncommon for people to have wine or different things with their lunches. 25% of women drink during their pregnancy in Europe. And I'll show you some data on their fetal alcohol syndrome rates, which really kind of confirms what happens when the alcohol levels are that high. In the United States, about 4% of people are frequently using, and about 10% use intermittently during their pregnancy. So still significant amount, but in comparison to Europe and Ireland, clearly a lot less. Next slide. So again, this binge drinking, I think, is an interesting part of it, because a lot of people do realize that they just should not be drinking every day during their pregnancy. What a lot of people don't realize is that intermittent drinking is not without its risks. And even in the United States, you've got, again, that 4% rate of binge drinking for their entire pregnancy. Other countries, it may range from 0.2% in the places like Saudi Arabia, some of the places where there's very little alcohol use, to 13, 14, 15, and even up to 20%. And if you look at some of the highest rates of pregnancy, the highest rates of drinking in pregnancy, really that underserved kind of racial ethnic groups are around 20%. Now, one of the areas that I think I'm sure that I failed at when I was doing obstetrics was understanding which groups were also at higher risk as they got older. And if we look at binge drinking in people who are a little bit older and 35 and above, that's actually one of the highest risk groups. Often over the age of 35, patients have more financial ability to buy things. They tend to be part of social groups. They may golf. They may do things where during their pregnancy, they tend to drink more over the age of 35 than sometimes we see in the 20s and the early 30s. And remember that when we're looking for binge drinking or want to consider it, it's really people who've had unintended pregnancies. They're younger. They might have other children, and especially with mental illness. Those are the people that we need to be screening even just a little harder, because they're the people that may not drink every day. And if they ask how many drinks you have a day, they may put 0. But if you said, have you had any times where you have drank at all in the last month, they may say once or twice, and with further discussion, find out that those are the times they're binge drinking. Next slide. And one of the things to remember is that half of the pregnancies in the U.S. are unintended. So again, that exposure in that first trimester can be very critical because, again, people don't understand at that time that they're pregnant. They're exposing their child quite a ways before that. And obviously, from an embryo standpoint, that's a critical time. That's when things are forming, and often the alcohol can be a real problem. I think it's always important as we go through all of the different types of substances we see in our clinics. We still focus so much on things that are illegal, if you will, the fentanyls, the methamphetamines, but still alcohol all by itself is the leading preventable cause. If we could stop people from drinking during pregnancy, it is the cause of most of the well, I'm having trouble there. Most of birth defects and developmental disabilities in the US. And so something that's legal, something that's accessible is still number one. And I think often we forget that. Next slide. So how about late trimester exposures? Again, I talked a little bit about this, the people over the age of 35, and I think that would be definitely the group that I would be least likely to really talk to, because my assumption with a white college graduate mom who's maybe a chief financial officer for some business, I wouldn't really be thinking, I'd be thinking that she would be smart enough to know that she should not be drinking at that time. But often it's social situations, it's certain groups that they're in, and they don't feel that intermittent drinking is going to cause a problem. And so, again, do not ignore any group. I think that every group needs to have screening. It needs to be universal. It needs to be sensitive, and it needs to be specific. Next slide. So how about maternal risks? It's not like just the baby can have a problem. I think it's important to understand that the risks of alcohol-related consequences go up with consumption. So it really, the more you drink, the more troubles you're going to have. It's very much the situation. The lowest risk for any health loss for a pregnant woman is 0, right? If you want to be the lowest risk, you have to be drinking 0, because any amount of alcohol can cause problems, including miscarriage, preterm labors, placental abruption and bleeding, especially in the heavier alcoholic drinking people, in the infections in the amniotic fluid, and of course preeclampsia and stillbirth. Any drinking really at all doubles the complications. So if they're drinking more than 5 drinks per week, you're going to basically double your risk of all of those maternal risks that are kind of listed above there. So imagine it doesn't take much to put you in a high risk category. Often that's unrecognized. Next slide. Oh, fetal outcomes. This is the fetal alcohol syndrome. Understand first, and I think I have a slide coming up, that there's something called there's fetal alcohol syndrome, which is one of many things that's under fetal alcohol spectrum disorders. And so we have to understand that the spectrum disorders has a whole list of things under it. One of the most common problems, of course, being fetal alcohol syndrome, which is depicted on the slide. There are many different types of structural abnormalities that can occur, whether it's kidney, heart, and of course some of the craniofacial issues that we see in patients, even in adults. But there can also be other malformities that can occur with alcohol. Now, there is, again, no safe dose of drinking that can avoid these issues, but I think that it is clearly dose dependent. The more you drink, the more likely it is. Next slide. And this is, this really, it's not like you're drinking in a vacuum either. Patients that are drinking alcohol are also frequently using other substances. And let's face it, smoking would be right at the top of that. And so other different issues that might affect the mom's health, including her nutritional status, whether she's smoking, what other types of substances she might be using, can also affect the fetus. So I think that we don't ever want to say, oh, this was just because of alcohol. Often it can be because of many other things that the patient has been exposed to. And often it is a long list of different things that people will use over a period of 9 or 10 months. Next slide. So how about the type and severity of defects? Again, the highest, when we look at the recent studies, they confirmed that sustained prenatal alcohol is the worst thing that you can do, right? So clearly that intermittent drinking is not great, but we know that when people have sustained intake, that does lead to some of the worst infant outcomes. And as I stated multiple times already, there is no dose in which an adverse outcome won't occur. I have seen a couple of cases in my career where patients literally only drank one time, and baby ended up with a fetal alcohol issue, but had significant intake early in pregnancy, and then did not drink again. Remember, just like many things, it is dose dependent. These effects are. Next slide. So I just wanted to put this up. I'm not going to belabor this, but I want people to understand that there's a spectrum disorder, right? Like many things now, you have a fetal alcohol spectrum disorder, and it can include any one of these different types of things. Some of these things actually will occur alone. Many of them will occur together. And so I am clearly not an expert in this, but these are some of the different syndromes that may be involved with the spectrum disorder. Next slide. So this is what I find very interesting because of some of the data that I put up earlier, especially when we look at Ireland and Europe. And I think Europe is basically done the study for us. You know, if 25% of your women are drinking, it's no surprise that your fetal alcohol syndrome rate is 3 times what the rest of the world is. And yet people keep going at that rate. I find this just fascinating that with a rate like that there hasn't been much more done that at least I'm aware of to try and bring that number down. And if you look at the women who are considered heavy drinking during their pregnancy, some of the women in Ireland, 1 in 23 will have a baby with fetal alcohol syndrome. So this is not something that is just not happening. It is happening a lot. Next slide. So how about treatment considerations? You know, one of the things that we have to ask ourselves when we see somebody who's using alcohol during their pregnancy is there anything we can do about it? I think when we see our fentanyl patients or we see people with particular problems, we sometimes feel like we've got some pretty good drugs to help them. And which of the drugs would be helpful for a pregnant person? Is treatment the way to go? Where are we going to get our best bang for our buck? And there's a big difference between what we would suggest for the general population and pregnancy. Okay. And again, when we look at what's at-risk drinking for adults, there is no such thing in a pregnant woman. There is no low-risk drinking in pregnancy. And so anybody with any intake needs to have some type of intervention. Next slide. So the 2 things we think about, and this is just like if they weren't pregnant as well, are there some psychological or educational interventions that we can consider that might help this patient? Or are there medications that we can use? And to be honest, I cannot think that I have had one patient in 2 years referred to me at the addiction clinic who was pregnant and drinking. I've had many pregnant and fentanyl and methamphetamine, which is a bit surprising when you consider, again, how common alcohol intake is in the pregnant group itself. And so let's talk a little bit about both of these, just so people have a little bit of an idea of what's been shown to be helpful. Next slide. So what is a psychosocial intervention? Well, it's all the things that all the treatment people do up on my floor here, which again, I'm no expert on, but it's very similar to what we would do with somebody who is not pregnant. It's educational sessions, it's motivational enhancement therapy, it's self-help groups, the AA, all these other things. It's cognitive behavioral therapy, it's psychotherapeutic techniques. All the same kind of treatment can be offered to people that are pregnant. Is there a lot of data that shows in pregnant people it works, or it works better, or it works the same? The answer to that would be there really isn't. There's very small amounts of information, which I'll show you. Next slide. And so there's been a couple big reviews. The first one was actually done in 2008 by a guy by the name of Louis. And he actually did a systematic review in 2008. Did it twice, looking at all the studies that have been done, looking at different types of interventions from a behavioral standpoint to see whether or not this would make much difference in the outcomes of babies and moms. And in fact, his study really showed very inconsistent results. And so we fast forward 10 years, and there was a couple other recent systematic reviews done by O'Connor in 2018. And he looked at, could they do behavioral counseling and try and reduce unhealthy alcohol use? And what he found that among pregnant women, it appeared if they had a very aggressive treatments, they were actually twice as likely to remain abstinent with intervention. So I do think there's value there. Now, they didn't list what percent of people were abstinent as compared to the other group, but they were twice as likely to remain abstinent. So it's certainly something that I think we would all do, is try and get a patient into treatment and to have that support and have that therapy and look at other things, whether it's, trauma-informed care and other things. Next slide. So certainly one of the tools in the toolbox. The second question is, can we give pregnant women medication? The $1 million question. And the first question would be, do we give pregnant women medications? And the answer right now is it's very rare. These are the medicines that we would use in somebody in general who are not pregnant. And I could probably add another 6 or 8 or 10 medications that are often considered in people who are drinking alcohol. Some that can be started when people are actually drinking, and some that can not be started when people are drinking. They actually have to be abstinent when they're started, or typically like a camprosate. So which of these have been studied the most or looked at the most in people who are pregnant? Next slide. One of the things here, naltrexone, of course, is something that we use very frequently. And I've said this in previous talks, that naltrexone is reasonably good. Again, the data, it is not like naltrexone is a grand slam. It blocks that mu receptor. It helps people maintain their abstinence and actually decreases alcohol consumption in general. But you might get 20%, you might get 25% of people who are real responders. And it varies from person to person. We put people on it, they have no response. The next person, it works like $1 million. A camprosate is another medication that has been looked at frequently for pregnant patients, but it is one that we use mostly for maintaining abstinence, typically started on patients after they have obtained abstinence. And so these are the two that most of the work has been done. A lot of it has been retrospective, like looking back, patients were on these medications, found out they're pregnant, stayed on the medications. And also when we look at some of the different animal studies, which we can talk about in a moment. But in general, when we look at these kinds of things, we want to make sure that we're going to have less harm on a medication than what we would if we were drinking alcohol. I don't think it's hard to imagine that medications, for the most part, it's going to take a lot of problems with them to make them more harmful than what alcohol can be. Neither of these medications has been associated with any significant risk of malformations or any other consequences. And so these are the two that are probably most talked about when we look at some of the research that's gone on over the last decade. Next slide. So if you're a mouse, and I don't think there's many mice out there, if you're a mouse, this is the drug for you, right? A camprosate, unfortunately, or fortunately, doesn't cause troubles with maternal or neonatal neurodevelopment. So from that standpoint, in mice, a camprosate appears to be completely safe. And in fact, there was one Australian study that was done just a few years back, and it showed that same thing. When they looked back retrospectively, they had a lot of pregnant women who were on a camprosate, went through their entire pregnancy, and they could not find any maternal or neonatal outcomes compared to control groups. One of the things, again, a camprosate is not a home run. It works for some people. It helps to maintain their abstinence. It's something that should be considered. But again, we have to always temper that with the fact that it's reasonably good, but not perfect. Next slide. And one sneeze.
Sorry.
When we look at naltrexone, and we use a lot of naltrexone in our clinic, both oral and injectable, and typically it's for alcohol. We don't use a lot of it for opioid use disorder. But there's been a lot of animal research done on naltrexone, and they give these mice and rats enormous doses of naltrexone to see if they can cause problems with pregnancy outcomes, maternal health, or any kind of congenital malformations. And in fact, even at 100 times the human therapeutic doses, there have not been significant issues. Once we get over 100 times the human dose, interestingly, your baby's going to get a little bit bigger. You may have a little altered pain response and a little bit of neurobehavior issues. So really, even at 50 to 100 times the human dose, we're not seeing significant problems in mammals that are typically in research. Next slide. So, I think that naltrexone has got to be one of those things that we think about in pregnancy. It's certainly something that I would consider because of the lack of really any fetal or neonatal outcomes that were bad. Some of the issues with naltrexone as an implant or an injectable have showed normal birth outcomes. We've not done that here as well. But again, I think this has to be on a case-to-case basis. I don't have much doubt that faced with this situation sent from the obstetricians that I would be considering these medications as well as treatment to try and get a healthy baby and a healthy mom down the road. But very clearly, you're going to have a very good conversation with mom and dad about the potential for risks, but the lack of any obvious evidence of risk. Next slide. So what's the bottom line? Well, the bottom line is we need further studies. But given potential risks associated with alcohol, which we know are significant, we probably should be considering these drugs in some cases. And again, informed consent, a lot of education, and careful monitoring, as well as involving our treatment facilities with these patients as well. Next slide. So one last thing, we're going to talk about withdrawal. When we look at patients who are going to withdraw in their pregnancy, half of these patients with long-term use are going to withdraw. And remember that if they're going to start having symptoms, typically if you can get them out to 24 hours, you're going to do pretty well. If they start having the visual or auditory or tactile hallucinations, and that will happen in 2 to 8%, you're going to have some issues. And 10% of those patients are going to actually seize. I got a phone call from a family who took their loved one to an emergency room, and she was seeing all kinds of things crawling around her walls and was hearing voices and was sent home because she wasn't seizing. And I sent her back, and she was there for quite a few days, didn't seize, but really took quite a while to get her out of that and to taper her down. Next slide. Remember, once we get to those kinds of symptoms, it's probably time to put that patient in the hospital. There's a lot of special considerations if a patient is pregnant. And I think that especially because if they have any significant symptoms, the possibility of abruption, preterm labor, and death is there. And those are all bad things. In case you didn't pick up on that, they're all bad things. So benzodiazepines in pregnancy are probably the most used when we see these patients. And I think a lot of places, especially because of pregnancy, are looking at the things like Librium and diazepam are probably the most used. Again, if it's third trimester, which it's obviously going to be if they're going to deliver, we have to always consider floppy baby syndrome. And these patients are probably needing to be delivered where there's a neonatal unit. And it's recommended that if this is a person that is not going to deliver, still they should be inpatient during their withdrawal. So remember, again, I think it goes without saying that still it's considered probably the best way to go symptom-driven as far as dosing, and not so much with patients just putting on a schedule. It seems that they do better if it's symptom-driven. Next slide. So here's the summary. Again, both of these things may complicate pregnancies. Probably benzos are a little safer during pregnancy than we previously thought. I'm still not a huge fan of benzos in general, but I do think that in specific uses are probably okay. There is no such thing as a safe level of alcohol, and I think that's the conversation we always have to have with patients as we screen them. And of course, not recognizing withdrawal and symptoms from alcohol and benzodiazepines, that can be life-threatening. So it's very important that we're very careful when we do that. So So that's my fun talk. If you want to take that down, Katie, there's a million sources, and you're welcome to download those and read every single one of them. It'd just be super fun. I think there's a few questions though. Do you want to?
Yep, we'll give everybody a break from hearing your voice here.
Perfect.
And go over the questions in the chat. So Melissa and Sarah had some good discussion about utilizing the 5 Ps. And if either one of you would be willing to unmute and chat a little bit more about that, that would be awesome. And then Melissa talks about a prevalence study in central Minnesota. So yeah, if you guys would be able to unmute, that would be awesome. Got another.
Yeah, so I'm curious about the 5 Ps and if there's a particular screening tool that is maybe the best or highest recommended for especially the OB patient population. We are looking at doing the 5 Ps, but some of the screening tools are really complex.
Yeah, and it's funny because, and I had looked into that before, the 5 Ps, and the 5 Ps is kind of a, as I recall, and it's been a while since I've looked at this, so correct me if I'm wrong. 5P is just more kind of a nice way of kind of doing an end around and asking about their family or friends and who drinks and whatever. And, you know, which honestly isn't that how that often is how I approach patients. Well, I'd say, oh, did you drink much in high school? Did you have friends hanging around that used anything? You know, try and get them to kind of talk about those things. But when you look at the 5 Ps up against, for instance, the NIDA screen, there are a lot of there's a lot of data that shows that some of the, I think it's the NIDA C or something like that, was considered a little bit more sensitive, I believe. But I think, I got to be honest with you, any kind of screening I'm really excited about, right? I mean, if we do any kind of screening, and I just had conversations with Catherine Duvall about the 5 Ps, and I know we're going to be having further conversations about that. I just think it's just having it in a way that the patient can really, you just have a really honest discussion with them, and they need to understand, boy, this is really important. You know, in my world, we worry so much about fentanyl and meth, but I often think I should be thinking more about alcohol, and I'm trying to change my way. So, right. Yeah, what has your experience been there as far as your screening with that? Have you been?
As far as for alcohol?
Yeah. Mm-hmm.
Yeah. So we actually, you know, the theory is that we would be aligned with the national average, you know, what that is. And so we did a prevalence study, and we actually did cord stat because it's too risky to lose meconium or urine because it gets thrown away or anyway, things happen in the patient rooms. So we do cord stat. And we did that 100% on all of our patients. It didn't matter how they screened. We just did it to check for prevalence. And actually, we're way below the national average. And the patient, we only had in the last probably 8 years, I think we've probably had just a handful, maybe 5 patients that actually had alcohol positivity. And we knew that because they admitted it to it.
Yep. Is that at the time of birth?
Yeah. And, you know, cord stat goes back a little bit. So it would have been within so much time, any exposure in the pregnancy. But we don't routinely, because of that, because our prevalence is so low, we aren't testing for alcohol routinely. So our cord stat, we're doing, I think it's the 12 panel. So, you know, the opioids and marijuana. And even all of those, when I compare to the national data, because US Detail gives us all of the data, comparing us, what we get, you know, every month compared to the national data that they get. And we're still way below the national average, at least here in central Minnesota, across the board for all substances. Even though it feels like it's really high, we are lower than the national average, and we're the regional site, so we get a lot of the transfers and maternal fetal medicine transfers here.
Yeah, that does surprise me. You know, being from north of here a ways, where I would have to say I see people out that are clearly drinking who are clearly pregnant. So yeah, that does surprise me. I won't mention any towns where I'm from, but yeah. You know, it's interesting that you talk about this too with the marijuana, because I actually just finished a talk on marijuana and pregnancy, and I'm actually as afraid of marijuana and the risks especially the first 8 years of a kid's life, probably just as much as I am now alcohol. I think that unfortunately we're going to be naturally testing all of these kids by exposing them over the next decade. So it really is significant. So we have a lot of work to do, right?
Yes, marijuana is a huge problem, especially for reporting purposes, because every county is handling it a little bit differently. Some are wanting those reports and actually following up, and some won't even accept a report if we report that it's positive for marijuana. So it varies so much that there's no consistency, and every person is handled differently by every social worker in their state.
Yeah, I have to say I'm excited because this little group that hopefully is going to kind of get together at Centricare, and we're going to really look at this strongly. I do think that working on this problem together is going to be hopefully really change some things. So I appreciate the reach out and having Catherine coming back to help. So, all right.
I have two questions.
Oh no.
So for the life of me, I couldn't remember what was the lab test that measured alcohol use over time, and that's the CDT, right?
Or
the PETH.
The EDT, I believe, is the one we use here. I can never remember
Okay.
But yes, that we can tell whether somebody's drank in the last 3 to 5 days, roughly. You can't. The problem with them is actually Centricare used those as a screening when you get hired. And if you're above 500, then it's considered, you probably drank a significant amount. But then the studies show it could be, the studies are not really great. It does tell you that there's been alcohol consumption, depending on how you metabolize it, when you actually drank, what it was, what you ate while you drank it. I mean, the number can be,
okay,
but it does tell you yes or no.
So it's not super definitive. I think my question was, would that be a diagnostic that would be used in kind of making the decision as to what to prescribe for a pregnant lady? Would that be a test that you would do? Have you ever done that?
No, and I think to me, and if anybody else has a different thought, I'd love to hear it. But to me, if I get a woman referred to me and she clearly is at-risk drinking, which is eating alcohol and is having difficulty stopping, I think they all should be evaluated for treatment. I think I would consider naltrexone and acamprosate for any of these patients based on the literature now. And I know it's been a bit of a push, but the number of people that are actually getting these medications or even evaluations is extremely small right now. And so here at Centricare, I think that's something we really want to change. So, yeah, I think she's nodding yes. So I think you agree. We need to really jump on this. So
I think resources are scarce and people don't know how or where to refer out to. And so there's some fear to even ask the question because then they don't know what to do with the answer if it is positive.
Yeah, that's very true. Yeah. Did you have a second question?
I just have a thought.
It's not about my tie.
It is not about your tie. It is not. But I just can't even imagine being a pregnant mom. I think, struggling with a substance use disorder is scary enough to disclose to your provider, and then being pregnant on top of it and all the stigma surrounding that and what you're potentially doing to harm your baby. It would be so scary to talk to somebody about that. So if anyone has any tips or tricks for the group on just to be less stigmatizing or have that difficult conversation, making moms feel more comfortable to disclose.
Yeah, and I think that's going to be one of the things that when our group at Centricare gets together is like, how do is it training some of the providers to do it in a way where it's not judgmental, where it's more like, there's a lot of things that could hurt your baby. Do you think you're doing anything that's concerning that we should really talk about? And let's, how can we help you? And as opposed to, boy, I tell you what, if you got any alcohol on that screen, I'm calling social services.
Yeah.
The last thing I really care to do, and I shouldn't say this when it's being recorded, but I don't like reporting people, right? That to me, it's
hard.
That screws everything up. It screws up their family. And so we want to get people into help right away. And we want to get them on the right track so that everything else is perfect. And so it's all about having the conversation in a way that's safe for the patient. They know we're not ratting them out to somebody. We want to get them the help so that their baby's perfect. and they're perfect when they're done. So
Right.
I think that takes a certain amount of conversation and training and what words to use and what words we talk about all the. She has a great talk about what words to use and what not to use, and that'll be coming up down the road. But I think, do you have anything to add to that? I mean,
Yeah, I think that the reporting thing is such a huge problem. Not everybody's on the same page. We have social workers here and locally that we've spoken to, and they absolutely mandate that we report everything, even though the statute doesn't support that. And so we're trying to support our staff to not report so that we can get patients into the right care and not have them afraid to come to us. But it's a huge conflict amongst everybody. And I know that this is a conflict amongst many people throughout the state. Because I hear the conversations at all the professional organizational meetings I'm at. We talk about it at the Maternal Mortality Review Committee. We talk about it all the time. There just isn't really great language in the statute at this point to help support us to not always report and to find the right resources.
So you don't have the advantage I have. I'm older, and so sometimes I forget what patients tell me, and I just get them help. But
You forget what everyone tells you.
No, but I do, and I think that one of the ways it's really changing the system. The system has to be changed that people have the ability to get the help that they need. And if they continue to fail, then maybe we have to step in and do things for the safety of the baby. But I think people have to be given a chance. And I think given that chance, most people are going to make the right choices and ask for help. And I think most of us would probably agree with that.
We had sort of, that rub that I think a lot of addiction programs feel with child protection and just all the questions surrounding that. So we had regularly scheduled meetings between our addiction team and our local child protection agency just to talk about what we're seeing. How do we work through these things, but yet do the same thing for the best thing for the patient and the baby on both sides, and what that meant and how to navigate. And that was helpful.
Yeah. So, well, we are about out of time. So on goes the war. I look forward to the work we're going to do here. And if anybody has any questions or needs further information, please feel free to reach out and be happy to talk to you. So thanks everybody for coming. We'll see you next week.